Welcome to another episode from the Veterinary Medicine Digest. Today, we're diving deep into a condition that can be quite alarming for any dog owner to witness: facial neuropathy, more commonly known as facial nerve paralysis. Imagine looking at your beloved canine companion and noticing that one side of their face is drooping. An ear hangs lower than the other, the lip on one side seems to sag, and their eye on that same side is wide open, unable to blink properly. It's a startling sight, and it immediately brings a flood of questions. What's happening? Is it painful? Will it be permanent? On today's episode, we will unpack the complexities of facial neuropathy in dogs. We'll explore the intricate anatomy of the facial nerve to understand why it's so vulnerable, detail the full range of clinical signs you might observe, and investigate the surprisingly long list of potential causes, from common ear infections to more mysterious, idiopathic cases. We'll also discuss how veterinarians diagnose this condition, what the latest research says about risk factors in certain breeds, and, most importantly, we'll cover management strategies and what the prognosis looks like for these dogs. So, join us as we explore the fascinating and often puzzling world of canine facial nerve paralysis. To truly grasp why facial neuropathy presents the way it does, we first need to take a journey along the path of the nerve itself. The facial nerve, also known as cranial nerve 7, is a remarkably complex structure. It's not just a simple wire sending one type of signal, it's a mixed nerve, meaning it carries different kinds of fibers that perform a variety of crucial functions. Think of it as a master cable containing wires for motor control, sensation, and even autonomic functions like tear production. The journey begins deep within the brainstem, specifically in a region called the rostral medulla oblongata. Here, we find the nerve's two main starting points, the motor nucleus and the parasympathetic nucleus. The motor neurons are responsible for what we call general somatic efferent functions, which is the scientific way of saying they control the muscles of facial expression. This includes all the subtle and not-so-subtle movements that make our dogs' faces so expressive: the twitch of a nose, the raising of an eyebrow, the movement of the lips, and the flick of an ear. It also controls a muscle involved in jaw movement, the caudal part of the digastricus muscle. From the brainstem, the facial nerve emerges and begins its trek toward the face. Its path is intimately intertwined with another important nerve, the vestibulocochlear nerve, or cranial nerve 8, which is responsible for hearing and balance. For a short distance, these two nerves travel together, snugly wrapped in a common dural sheath as they pass through a narrow bony canal in the skull called the internal acoustic meatus. This close anatomical relationship is critical, as it explains why diseases affecting one nerve can so easily affect the other, leading to the common combination of facial paralysis and vestibular signs like a head tilt or loss of balance. Once inside the petrous part of the temporal bone, a very dense part of the skull that houses the structures of the middle and inner ear, the facial nerve continues its journey alone, navigating through another tunnel called the facial canal. This is where the nerve is particularly vulnerable. At one point, the facial canal opens directly into the cavity of the middle ear, leaving the nerve briefly exposed. This anatomical feature is a key reason why otitis media, or middle ear disease, is a major cause of facial nerve paralysis. The inflammation and infection from the ear can directly impact the exposed nerve. As it travels through this canal, the facial nerve gives off several important branches. One of the first is the major petrosal nerve, which carries the preganglionic parasympathetic fibers destined for the lacrimal glands. These are the fibers responsible for producing the aqueous, or watery, component of the tear film. A lesion or damage to the facial nerve before this branch splits off can therefore lead to neurogenic keratoconjunctivitis sicca, or dry eye, a serious condition that we will discuss in more detail later. Another branch, the chorda tympani, carries parasympathetic fibers to some of the salivary glands and also brings taste sensation from the front two-thirds of the tongue. Finally, after navigating the complex terrain of the middle ear, the main motor trunk of the facial nerve exits the skull through an opening called the stylomastoid foramen, located just behind the external ear canal. From here, it fans out, distributing its branches to all the muscles of facial expression, allowing your dog to communicate a world of emotion without saying a word. Understanding this long, winding, and intricate path is the key to understanding all the different ways things can go wrong. When the facial nerve is damaged, the clinical signs are often dramatic and unilateral, affecting only one side of the face. The most obvious symptom is a loss of muscle tone, leading to a characteristic droopy appearance. You might notice the ear on the affected side hanging lower than its counterpart. The lip on that same side will sag, which can lead to drooling, not because the dog is producing more saliva, but because the muscles that normally hold the lip in place are paralyzed and cannot contain it. This is sometimes referred to as suboptialism. The nostril on the affected side may appear to deviate toward the normal, unaffected side, simply because the healthy muscles are pulling it over without any opposing force. One of the most concerning signs for owners and veterinarians alike involves the eye. The facial nerve controls the muscles that close the eyelids, so a dog with facial paralysis will have a widened palpebral fissure, meaning the opening between the eyelids is larger than normal. More importantly, the dog loses the ability to blink, both spontaneously and in response to touch, a protective mechanism known as the palpebral reflex. This lack of blinking poses a significant threat to the health of the cornea. Without the regular sweeping motion of the eyelids, the tear film isn't spread properly across the eye's surface, leading to dryness and exposure. This risk is compounded if the nerve damage occurs proximally, meaning closer to the brainstem before the parasympathetic fibers branch off to supply the lacrimal gland. When these fibers are affected, the dog develops neurogenic keratoconjunctivitis sicca, or dry eye, where tear production itself is severely reduced or absent. The combination of an inability to blink and a lack of tears is a perfect storm for corneal damage, predisposing the dog to painful and potentially sight-threatening corneal ulcers. A veterinarian can assess tear production using a Schirmer tear test, which measures how much tear fluid is produced in 1 minute. A dry nose, or xeromicteria, on the same side is also a hallmark sign of this parasympathetic dysfunction, as the same nerve fibers also supply the nasal glands. In some less common instances, instead of paralysis, the facial nerve can become irritated, leading to a condition called hemifacial spasm. In these cases, the muscles on one side of the face are in a constant state of contraction. This causes a narrowing of the palpebral fissure and a retraction of the lips, pulling them back almost into a grimace on the affected side. This can sometimes precede full paralysis in cases of middle ear disease or be associated with an intracranial mass. With long-standing or chronic paralysis, something similar can happen due to muscle fibrosis and contracture, where the muscles permanently shorten from lack of use, causing the lips to retract and the nose to deviate toward the affected side. So, what causes this nerve to stop working properly? The list of potential culprits is long and varied, which is why a thorough diagnostic workup is so important. Perhaps surprisingly, the single most common diagnosis is idiopathic facial nerve paralysis, often abbreviated as IFNP. A diagnosis of idiopathic means that after a complete investigation, no underlying cause can be identified. It's a diagnosis of exclusion. In a large retrospective study conducted in Sydney, Australia, between 2001 and 2016, idiopathic cases accounted for nearly 30% of all facial nerve paralysis cases. An older study from North America in 1987 reported an even higher figure, suggesting that idiopathic cases made up almost 75% of canine facial neuropathies at that time. The difference in these figures likely reflects both geographical variations in disease prevalence. For example, the Australian study had a high number of cases caused by tic paralysis, and significant advances in diagnostic imaging over the decades, which allow us to identify subtle underlying causes that might have been missed in the past. Idiopathic facial nerve paralysis in dogs is often compared to Bell's palsy in humans. In people, Bell's palsy is thought to be triggered by inflammation and swelling of the facial nerve, possibly induced by a reactivation of the herpes simplex virus. While a similar inflammatory or even viral cause is suspected in dogs, it has not been definitively proven. On magnetic resonance imaging, or MRI, some dogs with the idiopathic form of the condition show post-contrast enhancement of the affected nerve, which is a sign of inflammation and a breakdown of the blood-nerve barrier. This finding supports the theory of an inflammatory process, but doesn't tell us what triggered it. The onset of the idiopathic version is typically very sudden, with signs appearing and often reaching their maximum severity within about 24 hours. Moving on from the unknown, one of the most well-understood causes of facial neuropathy is disease of the middle and inner ear. As we discussed in the anatomy section, the facial nerve travels in very close proximity to these structures within the temporal bone. Inflammation and infection, known as otitis media or interna, are the most common cause of peripheral vestibular disease in dogs and cats and a very common cause of facial nerve paralysis. The inflammatory process can directly damage the nerve as it passes by the tympanic cavity. Other middle ear problems like masses, tumors, or polyps can also compress or invade the nerve, leading to dysfunction. In some severe cases, an infection in the ear can even extend into the cranial vault, causing a much more serious intracranial infection like meningoencephalitis or a brain abscess, which can produce central nervous system signs in addition to the facial paralysis. Trauma is another significant cause. This can be non-surgical, such as from a head injury in a car accident, or it can be iatrogenic, meaning it's an unfortunate complication of a medical procedure. The most common surgical procedure associated with facial nerve paralysis is a total ear canal ablation with lateral bulla osteotomy, a major surgery performed for end-stage, chronic ear disease. During this procedure, the surgeon works very close to where the facial nerve exits the skull, and despite careful technique, the nerve can be stretched, bruised, or inadvertently damaged. The incidence of this complication is quite high, reported in various studies as occurring in anywhere from 13 to over 70% of procedures, with cats being more susceptible than dogs. The good news is that most of these post-surgical paralyses are temporary, resulting from neuropraxia, which is a mild form of nerve injury, and function often returns within a few weeks to months. A wide range of intracranial diseases can also be responsible for facial neuropathy. Brain tumors, particularly those located in the brainstem or at the cerebellopontine angle where the nerve originates, can cause facial paralysis. Inflammatory conditions like meningoencephalitis of unknown origin or infectious encephalitis from agents like canine distemper virus can also affect the nerve's nucleus or its path as it exits the brain. Cerebrovascular accidents, essentially strokes, are another possible intracranial cause. We also see facial nerve paralysis as a sign of more systemic neuromuscular diseases. In certain geographic regions, like Eastern Australia, tick paralysis from the Ixodes holocyclus tick is a major cause. Myasthenia gravis, a disorder affecting the junction between nerves and muscles, can present with facial weakness. And a condition called acute idiopathic polyradiculoneuritis, which is an inflammatory disorder of the nerve roots, can also include facial neuropathy among its signs. Finally, certain systemic and metabolic conditions have been linked to facial nerve dysfunction. Hypothyroidism, or an underactive thyroid gland, has been reported as a potential cause, though the association can be complex. While one large study found no link when using strict diagnostic criteria for hypothyroidism, it did find an association when using less rigorous definitions, suggesting a potential for testing bias. Diabetes mellitus has also been implicated, as diabetic neuropathy can affect various nerves in the body, including the cranial nerves. And in some cases, a hypersensitivity reaction to certain potentiated sulfonamide antibiotics has been known to cause facial nerve paralysis. Given this wide array of potential causes, you might wonder if certain dogs are more at risk. Research has identified several predilections related to age, breed, and even gender. Let's start with age. Multiple studies have shown that facial nerve paralysis is predominantly a disease of middle-aged to older dogs. A large study from Sydney found that juvenile dogs under 2 years of age were significantly less likely to develop the condition compared to all older age groups. The risk steadily increased with age, with the highest incidence seen in geriatric dogs over 13 years old. The older Cornell study from 1987 reported similar findings, with a significantly higher risk in dogs aged 5 years and older. This age-related trend holds true specifically for the idiopathic form as well, with middle-aged dogs between 5 and 13 years showing a significantly higher occurrence. Now, what about breed? This is where the data gets particularly interesting. Certain breeds appear to be statistically overrepresented, suggesting a genetic predisposition. The Sydney study identified Cavalier King Charles Spaniels as having a dramatically increased risk for facial nerve paralysis in general, with an odds ratio of nearly 7, and an even more striking 17.5 times greater risk for the idiopathic form specifically. This breed is also known for a condition called primary secretory otitis media, or PSOM, which involves the accumulation of thick mucus in the middle ear and can occasionally cause facial nerve paralysis, though this was not identified as a confounding factor in the study's idiopathic cases. The study also found that Cocker Spaniels were overrepresented for facial nerve paralysis in general, and American Staffordshire Terriers showed a strong predilection for the idiopathic form. The older North American study also flagged Cocker Spaniels as being at very high risk, along with Pembroke Welsh Corgis, Boxers, and English Setters. These differences in breed predispositions between studies separated by decades and continents likely reflect changes in breed popularity and geographic location over time. Interestingly, when it comes to gender, the findings are a bit more nuanced. For facial nerve paralysis overall, Most studies have found no significant difference in risk between male and female dogs. However, the Sydney study did uncover a significant gender difference specifically for the idiopathic form. In their population, male dogs were found to have 2.3-fold increased odds of developing idiopathic facial nerve paralysis compared to female dogs. It's also worth noting that facial paralysis can occur concurrently with other neurological signs, which can provide valuable clues about the location of the problem. The most common accompanying sign is a peripheral vestibular syndrome, characterized by a head tilt, ataxia or stumbling, circling, and abnormal eye movements called nystagmus. This combination is very common because the facial nerve and the vestibulocochlear nerve travel together through the internal acoustic meatus. Therefore, a single lesion, such as inflammation from otitis interna or a tumor at the cerebellopontine angle, can easily affect both nerves simultaneously. Studies have shown that vestibular signs are present in a high percentage of dogs with facial nerve paralysis secondary to middle ear disease and intracranial disease. Curiously, vestibular signs are also seen in about half of the dogs with the idiopathic form of facial paralysis, suggesting that the unknown inflammatory process may affect both adjacent nerves. Another concurrent sign that can appear is Horner's syndrome, which is caused by disruption of the sympathetic nerve supply to the eye. This pathway also passes through the middle ear region, so it too can be damaged by otitis or surgery, leading to a constricted pupil, a droopy upper eyelid, a sunken eyeball, and a protruded third eyelid. When a dog presents with signs of facial neuropathy, the veterinarian's first task is to perform a thorough physical and neurological examination. The goal is to confirm the presence of facial nerve dysfunction and to look for any other neurological deficits that could help localize the lesion. Observing the dog's face for symmetry, spontaneous blinking, and normal ear and lip position provides the initial clues. The veterinarian will then test specific reflexes, like the palpebral reflex by touching the corner of the eye to see if the dog blinks, and the menace response, to assess the motor function of the facial nerve. A Schirmer tear test is crucial to check for neurogenic dry eye, and an otoscopic examination is performed to look for evidence of external or middle ear disease. Based on these initial findings, the next step is to try and identify the underlying cause. This often requires further diagnostic testing. If middle or inner ear disease is suspected, advanced imaging becomes essential. Both computed tomography, or CT, and magnetic resonance imaging, or MRI, can be used to evaluate the ear structures and the surrounding skull. A CT scan is excellent for defining bony structures and can reveal changes in the tympanic bulla, the bony cavity of the middle ear. However, MRI is generally the preferred modality because it provides superior detail of soft tissues. An MRI can visualize the fluid within the inner ear, the nerves themselves as they pass through their canals, and the brain parenchyma. In cases of otitis interna, for example, an MRI might show a loss of the normal fluid signal in the inner ear, thickening and contrast enhancement of the nerve, or signs of inflammation extending to the meninges, the membranes covering the brain. When investigating idiopathic facial nerve paralysis, MRI can be particularly insightful. As mentioned earlier, a key finding in some of these cases is gadolinium contrast enhancement of the affected facial nerve. On a normal MRI, the facial nerve doesn't typically enhance after contrast is given. This enhancement indicates inflammation and a breakdown of the blood-nerve barrier. One study found that the presence and extent of this enhancement might even have prognostic value. Dogs with enhancement in multiple segments of the nerve had a poorer prognosis for full recovery compared to those with no enhancement or enhancement in just a single segment. However, conventional MRI techniques can struggle to visualize such a small nerve accurately, and newer, high-field MRI with thin slice, 3D sequences have been shown to have much higher sensitivity for detecting these subtle abnormalities. If there's any suspicion of central nervous system involvement. For example, if the dog has seizures, changes in mentation, or deficits in other cranial nerves, an MRI of the brain is the imaging modality of choice. In these cases, a cerebrospinal fluid analysis, or ACSF TAP, may also be recommended. Analyzing the fluid that bathes the brain and spinal cord can reveal evidence of inflammation or infection. One study on dogs with concurrent facial and vestibular neuropathy of unknown origin found that 69% of them had a finding called albuminocytologic dissociation in their CSF, which means there was an elevated protein level with a normal cell count. While not specific, this finding is a hallmark of certain inflammatory nerve conditions and adds weight to the theory that many idiopathic cases have an underlying inflammatory cause. Other diagnostic tests may be run to rule out specific systemic causes. Blood tests, including a complete blood count and biochemistry profile, are standard. If hypothyroidism is suspected, a full thyroid panel, including a thyroid-stimulating hormone stimulation test, is the gold standard for diagnosis. The management of facial nerve paralysis hinges on two key principles. First, treating the underlying cause if one can be identified, and second, providing supportive care to manage the secondary effects of the nerve damage, particularly to protect the eye. If an underlying cause like otitis media or interna is diagnosed, treatment will focus on resolving the infection with appropriate long-term antibiotics, which may need to be chosen based on their ability to cross the blood-brain barrier if there is intracranial extension. In cases of severe, chronic otitis, surgery like a total ear canal ablation may be necessary. If an intracranial disease like meningoencephalitis is found, treatment will likely involve immunosuppressive drugs like corticosteroids. For cases linked to hypothyroidism, thyroid hormone supplementation is the treatment. Regardless of the cause, the most immediate and critical management concern is protecting the cornea. The inability to blink and potential decrease in tear production puts the eye at high risk for drying out, leading to keratitis and ulceration. Therefore, prophylactic lubrication is essential. This usually involves the frequent application of artificial tear ointments or drops throughout the day to keep the ocular surface moist. If neurogenic dry eye is confirmed, specific treatments may be initiated. One such treatment is oral pilocarpine, a parasympathomimetic drug that can stimulate the tear and salivary glands directly. While its use is not backed by large clinical trials, it has been shown to be effective in many cases, often leading to a resolution of both the dry eye and the dry nose. The prognosis for recovery from facial nerve paralysis is highly variable and depends almost entirely on the underlying cause. For dogs where the paralysis is a complication of a total ear canal ablation surgery, the prognosis is generally good. Most of these cases are temporary, and function typically returns fully within several weeks to 3 months as the bruised nerve heals. Similarly, cases caused by neuromuscular diseases like tic paralysis often have a good prognosis for recovery once the primary disease is treated, with nerve function often returning within a couple of weeks. For the most common category, idiopathic facial nerve paralysis, the prognosis is much more guarded. Recovery can be a long and unpredictable process. Some dogs show gradual improvement over weeks to months, while others may be left with permanent deficits. One study found that only about 37% of idiopathic cases with known follow-up showed definitive resolution within 3 years of diagnosis. Another study reported complete resolution of facial paralysis in 39% of dogs with concurrent idiopathic facial and vestibular neuropathy. This means that a significant portion of dogs, perhaps more than half, will not regain normal function. In these dogs with incomplete recovery, a long-term complication called hemifacial contracture can develop. This is a result of fibrosis and permanent shortening of the denervated facial muscles, which leads to a permanent retraction of the lip and narrowing of the palpebral fissure on the affected side. While this can cause a permanent change in the dog's facial expression, it doesn't typically cause pain or significantly impact their overall quality of life, though some may require lifelong eye lubrication to prevent ocular issues. The prognosis for cases caused by more serious issues like intracranial neoplasia is often poor, and humane euthanasia is sometimes elected due to the progression of other neurological signs. In conclusion, facial neuropathy in dogs is a complex condition with a multifaceted presentation and a wide spectrum of causes. From the intricate pathway of the facial nerve making it susceptible to injury, to the startling clinical signs of a drooping face and an unblinking eye, it presents a significant diagnostic challenge for veterinarians. While the most frequent diagnosis is idiopathic, a thorough search for underlying causes like ear disease, trauma, or intracranial pathology is paramount, as this will guide treatment and determine the ultimate prognosis. Management is centered on protecting the vulnerable cornea and addressing the primary problem when possible. For many dogs, especially those with the mysterious idiopathic form, the road to recovery can be long, and a complete return to normal is unfortunately not guaranteed. However, with diligent supportive care, most of these dogs can continue to live happy, comfortable lives, even if their smile remains a little lopsided. Thank you for listening. The titles for the referenced papers are in the video description. From Vet Med Digest, where we keep minds inspired, hearts light, and tails wagging.